By far, the most deaths from COVID-19 in Ontario have been seniors in long-term care. The situation was so bad, the province had to ask for the military to be called in. Now, with a second wave bearing down, have we done enough to protect those living or working in those settings? Let's get into that. And as is our custom on this program, we'll introduce our guests from furthest away to closest to our studio in that order. And so we start in Innisfil, Ontario, with Sharleen Stewart. She's the president of SEIU Healthcare, the union that represents more than 60,000 frontline healthcare workers in this province. In Streetsville, Mississauga, Dr. Amit Arya, a palliative care doctor who works in long-term care facilities and holds a joint faculty appointment in the Division of Palliative Care at McMaster University in Hamilton and the University of Toronto. In the St. Lawrence Market neighbourhood of the provincial capital, there's Donna Duncan, Chief Executive Officer at the Ontario Long-Term Care Association. And in the downtown core, Dr. Samir Sinha, Director of Geriatrics at Sinai Health and the University Health Network. And it's really good of all four of you to make some time for us and our viewers and listeners tonight here on TVO. I want to start just by putting up some facts that will set up the discussion to come. And Sheldon, if you would, let's bring that graphic up. Long-term care deaths account for 2/3 of the deaths from COVID-19 in this province. There are 626 long-term care homes in Ontario, of which more than 400 have had outbreaks. Now, a reminder, one case is considered an outbreak. At the start of this week, 101 homes had outbreaks. That's about 16% of the province's homes. And as of Monday of this week, there were 528 residents and 467 staff members with the virus. Now, let's start with this. The province's official line is, yes, we're into a second wave of COVID-19, but we did learn a lot of lessons the first time around, and therefore we're doing much better this time around. I want to start with a basic question. True or false? Dr. Sinha, start us off.
Well, I think, the second wave, we're seeing more deaths again, we're seeing more outbreaks, and sadly, we're seeing a lot of the issues that weren't addressed in the first wave that are creeping back to hit us again in the second wave. And I really think it's just unparalleled levels of community transmission and the staffing issues that really haven't been resolved that I think are the Achilles heel of a good pandemic response. That's why I think we're seeing outbreaks again and preventable deaths once again.
Sharleen Stewart, we're doing better this time. True or false?
False. For all reasons. They didn't do enough preparedness over the summer. The things that they did were verbal commitments, but we're not seeing the actions implemented inside the homes. We're seeing a more critical staff shortage. It's been reported that 30% of the staff that were there during the first wave are not returning during the second wave. So it is worse. I mean, some of the lessons learned, like the low wages, there was a commitment to address that, but the piecemealing way that we're dealing with this pandemic is not making any improvements. Things are actually worse.
Dr. Amit Arya, what do you say? True or false?
Yeah, so absolutely. I would agree with the other panelists that our response has been piecemeal, ad hoc, and really far too late in many of the homes that have large-scale COVID-19 outbreaks. So really, it's false. And we could have done much better over the summer and learned even from other provinces that had a much better response.
Well, Donna Duncan, I've left you for the end for obvious reasons. I wanted you to hear what everybody else had to say first. How do you weigh in on this?
Certainly, we're better off in knowing about asymptomatic spread and PPE and testing, but we have a critical staffing shortage right now, and we still have old buildings, and we know that the root cause is in wave one, where we had community spread, old buildings, and staffing shortages. So we have a lot to do to still stabilize the sector.
Tell me what you think, Donna, has changed in terms of how long-term care homes are better prepared this time around than during the first wave. What's different now?
Certainly the response for help is much faster this time. In the first wave, it wasn't until the middle of April that we were able to get reinforcements in. Certainly we've been working with the government to say, we can't wait days, we can't wait weeks, we can't wait months. When we know that we have an outbreak that may be escalating, we need to get help as quickly as possible. And certainly working with public health and with hospitals and local communities, especially where we have large outbreaks, that helps going in more quickly. And we need that.
Samir, we know that when the Canadian military was called in earlier this year, that report really revealed some pretty horrifying stuff. In fact, I think Premier Ford said at the time it was the scariest report he'd ever seen. Heart-wrenching, I think, actually is more accurate of what he said. In your view, since then, what's changed?
There's been a greater recognition about how vulnerable long-term care homes are. And as you mentioned, that we've seen the majority now have experienced an outbreak. And we've seen over 2,300 deaths now occurring, in these settings. So this is a real challenge that we've really had to struggle with. But I think the key is that the government is making commitments. They're saying we recognize that we have to improve staffing. We recognize that we need more supports for the sector, that we have to actually increase the levels of care we're providing. The key is that, how do we actually make those structural commitments happen quickly and in a timely way, and really change the overall culture of long-term care, where we saw in that military report, staff talking about a culture of fear, staff being told by some operators, don't use the PPE, it's too expensive, for example, and a culture where staff just feel that they're not being supported. So as Sharleen said, 30%, 1 in 3 of the 100,000 staff members that were working perhaps in our homes in the first wave are not returning. That's a huge problem, and that really tells us that a lot of people, the staff included, are losing confidence in the sector, and we have to change that quickly.
Sharleen, how much of that happens? How much of staff being told, don't use PPE, it's too expensive, use it sparingly? How much of that do we really hear?
Yeah, unfortunately, it still does happen. And again, with the outbreaks, the ability to get a hold of higher grade like N95s is still a challenge. The infection prevention control measures in the homes, because of the crisis in the staffing, is not good enough. They've got staff working on multiple floors, using the same mask that they've used on, say, an infected floor. Because of the staffing shortages, they have to spread those staff among many floors, and that is a bad way to contain a virus or a presumed virus.
Having said that, Amit, I do remember Brian Mulrooney once saying, don't compare me to the almighty, compare me to the alternative. So let's find out, relatively speaking, how Ontario is doing vis-a-vis other provinces. On that score, what do you find?
Well, I think really the gold standard that we can compare ourselves to is British Columbia, which acted very early on in the pandemic back in March to take critical actions. They acted decisively with clear communication for the entire long-term care sector, specifically when it came to public health supports, infection control, and prevention, along with staffing. What they did is they nationalized the long-term care sector, which means that the government actually hired all frontline long-term care workers, made sure that they were only working in one home, being paid a decent living wage, benefits, and sick leave. And consequently, through the first wave, what happened is that they have half of the long-term care sector, but had 1/10 of the deaths. And here in Ontario, we still have this loophole in the directive where agency staff can actually still move between homes.
I've heard conflicting things. Donna, maybe I should go to you on this. I've heard conflicting things on ownership style as to whether or not a home owned by the public, operated by the public, as opposed to privately, makes a difference in outcomes. What can you tell us on that?
So certainly, Steve, the research that we've done would demonstrate that if there is no difference with ownership is not a factor. And certainly in this wave, we are seeing municipal and more nonprofit homes being impacted by this. The key indicators are community spread, old buildings, staffing shortages. These are really the critical root causes. And we need to focus on, to Samir's point, how are we going to fix these issues right now and quickly and restore confidence in this sector so that we can ensure that we've got the staff we need to keep our residents safe?
Amit, can you come back on that? Again, I have heard the same conflicting things about whether the ownership style matters. You seem to say in British Columbia that it does. Does it really?
Yeah, so I mean, of course, it's not the only factor. And, Donna is absolutely right that there are sort of homes that are not for profit or municipal that are having a hard time and actually weren't providing proper care even before the pandemic. And there's very good for-profit homes as well. But of course, for-profit status is a critical issue that has come up during this pandemic, and it needs to be addressed. I mean, we know that private for-profit homes had a poor quality of care in general before the pandemic, with a higher rate of hospitalizations and deaths. And they also disproportionately have more deaths at this time during the second wave and the first wave.
Sharleen, where do you come down on this issue of whether ownership mode matters?
Absolutely. I mean, over this first wave, we've got lots of data, lots of statistics. It's proven that the for-profit homes have 17% fewer staff, and that was before the pandemic. It's worse now. So the facts are there. I don't agree with Donna. I mean, the for-profits, yes, of course, there's been some good ones, but strangely enough, the ones that were spared during the first wave are seeing the infections now. And, you know, the data's all there. They do hire fewer staff. And that's the result of the consequences of how many infections and deaths appeared inside those for-profit homes. And again, right now there is support coming in, but where is it coming from? The public sector. Hospitals are coming in to support those homes. So we need to make that a permanent way of delivering care, not just when there's a crisis going on in healthcare or in long-term care.
Samir, just before I get you to comment on that, let me, Sheldon, our director Sheldon Osman here, can I call an audible? Let's go to bottom of page 3 and bring up this graphic here from the Toronto Star analysis from earlier this month, because here's what the Star found when they looked into this. They discovered that among homes with at least one confirmed infection since August 1st, the Star's analysis shows for-profit homes have struggled to stop the spread of the virus. Residents in for-profit homes have been more than 3 times as likely to catch COVID-19 as those in a nonprofit facility, and for-profit have seen more than twice as many staff infections per bed. Resident deaths have been more common too. Now, what that analysis I don't think suggests, or what it doesn't indicate, is whether or not these are older for-profit homes versus newer not-for-profit homes. It suggests that the ownership model is the reason for these higher rates. What can you tell us on that?
Well, what we do know is a colleague of mine, Dr. Stahl, and others actually were working in partnership with the ministry to do a study. And Donna and the Minister of Long-Term Care, Marilee Fullerton, have talked about the study. And what it really showed was that community transmission is the biggest risk factor that will determine whether a home gets into outbreak, regardless of ownership status. But what the clear signal from the papers were showing was that actually, if you were a for-profit home, you are more likely to have a larger outbreak and a larger number of deaths. And largely, a lot of the factors here were related to chain ownership. So if you're part of a big chain, and if you actually, and many of these chains actually own older homes. So we have to remember that 1 in 3 people living in an Ontario long-term care home is actually living in a 4-bedded room. And these are buildings that are over 50 years old that have not been developed. Many of the not-for-profit and municipal providers have actually redeveloped their beds so they're up to modern standards. But about 50% of the for-profit beds in Ontario have not been redeveloped. And that's a problem, because then you're packing people into crowded rooms. And there hasn't been a lot of movement, frankly, over the past few months in actually decrowding these homes. We've continued to admit people. And unfortunately, we still have people 4 to a room. And that's why in this second wave, some of the biggest spectacular outbreaks yet again are in these older, crowded homes where they were literally like kindling that we just threw a match in. And we knew that this was going to happen. We had the data. We didn't actually act definitively, and especially around the staffing issues. These are the challenges. And this is what the data told us that we needed to do.
Okay, but Sharleen, I'm going to go back to you one more time on this thing, because this is the thing I'm really trying to get to the bottom of. Is it the ownership model itself, the private versus not-for-profit, that is the issue here? Or is it the fact that many of the, as Dr. Sinha puts it, many of the places where it's like kindling happen to be privately owned, but that's not the issue. It's actually the fact that it's 4 to a room, it's that they're older, all of those issues. Help us understand.
Yeah, well, it's a combination of all of that. But again, it's so simply put, it definitely goes back to staffing. I mean, building new homes, yes, they're needed. But again, if you do not have the staff to work in those homes, then we're still going to have the same problem existing. The fact that the for-profit homes, I mean, take a look at they take the public money that's given to them to take care of seniors. They take from that money and they pay the shareholders. Now, that means that there has to be cuts somewhere. Where's the first place that they do it? They do it in staffing. And why aren't they taking a look at improving some of their own structures as well? So again, I say It's a combination of all of it, but still, the shiniest new model without proper staffing, we're still going to have problems.
Okay, I do want to pick up on that issue of staffing. And Donna, I'll go to you first on this one. We learned 17 years ago with SARS that one of the best ways to encourage a virus to be as contagious as possible was to have personal service workers and long-term care home workers work in as many homes as possible. And so the recommendations came out, one worker per one home. And that's how you nip this thing in the bud. What I need to know today is whether or not that protocol is being followed across the province of Ontario. Do we still have one PSW per long-term care home, as has been recommended for 17 years?
Well, certainly in the first wave, we moved to one single site for staff. I believe Amit mentioned that agency staff are not subject to that, but with this wave, we really are abiding with that. As Sharleen says, we do have a critical staffing shortage right now, and we are working very, very hard with government to try and boost our reserves, I would say. But because if we don't have people, we can't keep people safe.
Amit, do we have a situation in Ontario today where it's one staff worker to one home only, or are they still working in multiple homes? Are too many still working in multiple homes?
Well, the honest answer is we don't know, because this is not being tracked by the ministry, but it's obvious that this would increase the spread of the virus. And as Sharleen and Dr. Sinha have said, I mean, we're in the middle of a critical staffing shortage at this time, and we should have done so much more through the summer to make sure that all health workers in these homes were full-time, being paid a decent living wage, and were only working in one home. Conditions of work determine the conditions of care.
Sharleen, I saw the Premier stand at the podium during one of his daily briefings and say, we're going to offer lump sum benefits to people who go into the personal support worker profession. We're going to up their pay. We're going to do what we can to make sure they only work in one home, one location per person. Is that not having an impact?
It's having a negative impact, quite honestly. I mean, the fact that the permanent workers that were there before the pandemic, 68% of them have reported to us that they are financially in worse condition than they were before. In their words, they're being exploited, and predominantly it's women. They are making less money than they did pre-pandemic because they are confined to one home. One of the things I encourage the government to do is, like BC, keep them whole, give them a universal wage rate, and give them full-time work. The fact that the agency staff do not have to follow the same rules and conditions as the permanent staff, and I'm not saying full-time, but the permanent staff in there, is a real problem. So this has not attracted, as I said, 30% of these workers feel like they are just being left out. And to say that we'll give you a wage increase, to recognize that you are poorly paid, but we're only going to do it for 6 months and then put you back into poverty, they're not accepting that anymore. And then instead of increasing the wages, they're introducing lower paid, lower trained staff to come in there. They're going backwards. Everybody is racing to the bottom instead of dealing with the issue. Stop exploiting these predominantly women, pay them what they're worth, give them full-time jobs with benefits, and watch and see how the system improves itself.
Samir Sinha, out of the corner of my eye, I saw you nodding through much of that. What can you add to that?
Well, I mean, you have to look at the different approaches. Quebec announced back in May they lost 10,000 frontline workers, personal support workers. So they went out deliberately. They said, we're going to promise full-time work. We're actually going to hire. They hired 10,000 people. They recognized that for these women, to actually take a few months to do training, how are you going to put food on the table? So they paid them for their time in training, and then they guaranteed them a wage rate of at least $26 an hour. And that actually acquired 10,000 new frontline staff by September. And we actually have less homes in Quebec currently in outbreak, and we had more homes in Quebec in outbreak than Ontario during the first wave. And now we flipped that course. So there are key ways in which we could actually stabilize our staffing. BC, Quebec, and BC's even hiring 7,500 new workers. But as Sharleen said, what they did was they guaranteed everyone single site full-time pay, and they made sure that everyone was being paid an equal top level rate. And that really did favors, because that cost BC $10 million a month, so $120 million a year. And Donna can correct me if I'm wrong, but I think we spent $1 billion, in Ontario to try and shore up our long-term care homes. And frankly, we have 2,300 people dead, 10 times what BC has. So, do the math and see how half-assed, kind of limited approaches, don't really get us that far.
Donna, you want to weigh in?
Well, absolutely. We have a lot of work to do on our staffing, and we saw what was happening in other provinces throughout the summer months. We lost time. We lost time. We need to stabilize the workforce. We need to respect those employees who've stayed and worked through. Bonuses for people who are new coming in doesn't recognize the work and the commitment of our frontline staff who've worked in our homes for years. We need to validate them. We need to make sure that we're getting these new compensation models in place. To Charlene's point, we've had lots of announcements, but we haven't seen the cash flow.
Well, okay, let me follow up on that, Donna. I'm certainly sensing a consensus here about what it would take for improvement. If we know what it would take, why are we not doing it?
It's a great question. Certainly, we've been advocating and working with our colleges over the summer months. How do we build in experiential learning into our homes? Why can't we have paid positions for PSW students to come in and learn on the job and get both their practical and academic learning in the home in real time? Why can't we do that?
What's the answer? Why can't we do that?
I don't have the answer. I wish I knew. I've been asking because it seems other provinces have done it. We've certainly done it in other sectors. If there's a will, there's a way, and let's just clear out the weeds and make this happen.
Okay, Amit, let me find out from you. What are you hearing from residents today in long-term care homes in this province about how relatively safe or unsafe they feel now?
Well, they're very scared, because some of the critical changes that we needed to have happen haven't happened. I mean, I'm a palliative care physician who works frontline in these long-term care homes and has worked in homes with large-scale COVID-19 outbreaks. And a fundamental problem that happens when homes go into outbreak is that you have this virus, which is, of course, spreading very rapidly. And this virus it can cause rapid decline in residents in terms of their health, where they can develop breathlessness or delirium. And they need close monitoring. And basically, they need more care and not less during an outbreak. And that's not happening because what happens is that the staffing levels plummet at that time because many of the staff, unfortunately, fall ill themselves and are sick at home, and isolating. And as someone who's led these response teams into homes, I mean, what we really saw is that there just weren't enough staff in these homes. And we actually need a reserve force ready to step in at the first sign of any trouble in these homes, whether it's a hospital response team or a community-based medical teams. The threshold for intervention has to be very low, and we have to do all we can to protect the well-being and lives of our seniors.
Amit, Quebec got 10,000 new people pretty much with the snap of a finger. What do we need in Ontario? How many?
Yeah, so I think we absolutely need to do much more. I can tell you that experts and family caregivers, advocates, and researchers have been calling for decades for 4 hours of hands-on direct care per resident per day. And, the average prognosis, the average life expectancy in these long-term care homes is 18 months. And our province's commitment is to make that happen in 4 to 5 years. How do you think that makes, residents and family caregivers feel? It's atrocious. We need to step up and have permanent funding and a timeline to make this happen now. This is an emergency, right? What's really happening is that there's not enough staff to do critical duties like bathing and feeding and also monitor people medically. So there needs to be much more proactive action and investment. And if we talk about the tragedy that's happened and we say never again, that means action has to happen today.
Samir, I do want to follow up on this issue of 4 hours of hands-on care per day per resident. Again, I saw the Premier go to the podium during one of his daily briefings and commit to making that happen. Now, he didn't say it would happen tomorrow, but he did say that they would get there soon. What's the status of that promise right now?
Well, here's the challenge. Right now, in an Ontario long-term care home, we provide about 2.75 hours of direct hands-on care a day. And it was actually the Ontario government's own staffing commission that came out back in, I think, about June-ish, and actually said 4 hours a day is where we need to go. The Long-Term Care Commission was not asked to make any recommendations at all, from their work. They came out with interim recommendations a week before the budget and said, stop studying the study, move on 4 hours a day. I was thrilled when I saw the pre-budget announcement saying we're going to do it. We're going to move by 2024, 2025, 4 hours a day. And then budget day happened, not a single dollar for that line item. Premier was asked, what's going on? They said, we're committed to it. The Minister of Finance said, we'll get the money when we need it. Well, you can hear we need the money now. And I think even if we just said, because this is a $1.6 billion top up on what we currently fund to reach that 4 hours a day. So if we have the money, and apparently we have lots of money lying around, let's get this done so that we're not struggling and having the same conversation for wave 3.
Well, let me do a follow-up with you on that, because you're quite right. There was nothing specific. There was no specific line item in the budget that said this is for 4 hours hands-on care per resident per day. But the finance minister did say, I will find the money when we are ready to go. He's got $3 billion in a contingency account, not to mention $9 billion in another fund that he got from the federal government. What's holding this up, do you think?
I have no clue. I mean, right now you hear, we actually have staffing shortages all over the place. I know that about 80% of our homes were struggling with staffing before the pandemic started. And the average time that a person spends working on the front lines in long-term care is sometimes about 18 months. So we're not doing a great enough job, and we're just burning through staff and burning up goodwill. And the challenge is that now we did some surveys over the summer through the National Institute on Aging, and we found that 78% of Ontarians say they rather receive care in their own homes than in a long-term care home. 100% of people 65 and older say, I want to stay at home for as long as possible. I think the public have frankly been losing confidence in our long-term care system, and I think our staff are too, and that's hard to reclaim over time. So there's no time like the present to get started.
Donna, what's your understanding of where the 4-hour commitment is at today?
They're planning. It's the ministry's planning. They're certainly working on how to get that first extra hour of care in place. To Samir's point, our challenge is going to be getting the people to provide that care. It takes us 4 years to train a nurse. We know that the environment matters as well in terms of getting our staffing in, and this is going to matter. It takes 3 to 5 years to build a new home. We need to grow people and new buildings, and we need to restore confidence. The population over 80 in Ontario is going to double in the next 15 years. And unfortunately, not everyone's going to have be able to age at home. And so we know we've got to get the pieces in place, but we need to get through wave 2 and be ready for wave 3. And we need to attract a new workforce as quickly as possible and upskill the one that we have. To Charlene's point, we need more skills, not less, and we need more people.
Sharleen, this is a government that frequently says, we are tearing down regulations, we are damming the torpedoes, if you like, we are making sure that we can get this stuff done lickety-split in lightning-fast record time. Do you see that happening?
No. And that's why workers are leaving. They have no confidence in the words that come out of the Premier's mouth anymore. They're nice words, but the action, they don't see it. It's those frontline workers, predominantly women, who are carrying the burden of this crisis, and they're not going to do it. I mean, 4 hours of care, yes, it's been decades that we've been asking for that. But again, there's not enough staff to even provide those 4 hours of care. So to say it and not be able to implement it is just adding to the lack of confidence these workers are having. One of the residents said he'd be dead by the time that there was an increase in that. And with the levels of care increasing in senior care, we might need 5 hours in 4 and 5 years, not 4. So it needs the political courage and will to do things now.
Dr. Sinha, maybe you could just explain, because when you look at the numbers, if you go from 2.75 hours per resident per day of hands-on care to 4 hours a day, that may not, from 2.75 to 4, may not look like a big increase. But let's understand that. What can you do in 4 hours that you can't do in 2 3/4?
Well, it's the idea that when you think about the typical resident in a long-term care home in Ontario, the average age is about 85, 90% have cognitive impairment, 70% have dementia. And we talk about, having challenges with bathing, dressing, feeding, toileting. These are people who need incredibly high levels of care. And right now, with 2.75 hours of care, a lot of things just aren't getting done. And we hear this repeatedly. And Dr. Arya was just mentioning how, for example, when there's an outbreak, and there's even less staff available, just less things get done, like feeding, dressing in an appropriate way. So what we have to recognize is that the complexity of the residents who are living in these settings has increased. And so this means we need more frontline personal support worker time. We need more RPN time. We need more RN time. This is the time that we need. And frankly, and we're talking about tens of thousands of workers that would actually need to make up that 4-hour commitment. But again, I don't understand why Quebec, our province next door, could go out and in 3 months staff up 10,000 new people. They showed it could be done. So I'm not sure why we need to continue thinking and planning. And as the Long-Term Care Commission said, stop studying the study. Just get on and do it, because frankly, we have 300 more people dead now in the second wave. I don't know when we're going to finally pull the trigger and put out a shingle and say, we're hiring, we're ready, let's get this done.
Well, Amit, we've got the Minister of Long-Term Care coming on right after you four. I'm all ears as to questions you might want me to ask her, or what you've got on your wish list for her. Fire away.
Well, I think there's a lot of things that we've all talked about today that are so important. I mean, we've got to make sure that we address the staffing crisis. I mean, that's the first step that we all agree on and we've spoken about. I mean, all the health workers need to only be working in one home. They need to be full-time. They need to be given a decent living wage, sick leave, and benefits. We need to move to the 4 hours of care standard that everybody has been asking about. We also need to make sure that we enshrine the rights of essential family caregivers under the law, to make sure that what happened in the first wave, where people couldn't even see their loved ones for 6 months, never happens again. We have to make sure that we have hospital and community-based medical teams on standby, ready to step in with a very low threshold of intervention. And for that to happen, we need full transparency from all homes about what's going on inside, so that critical help can be provided. We need to hold all long-term care homes, especially private for-profit long-term care homes, accountable for tax dollars spent as well as quality of care. And I'll be honest with you, like with everyone listening and watching today, that I think at this point in the pandemic, months in, we just keep on hearing numbers and deaths day after day. But these people are much more than cold, hard numbers. I mean, they're human beings. They're somebody's, parent, grandparent, aunts, and uncle. I mean, they have real life stories that we can all learn from, and they deserve absolute dignity and respect at this time. I mean, we have to redesign our whole long-term care system to make sure that we give seniors, the life they deserve, and the time is now.
That's a good exhaustive list. Sharleen, what would you add to that list of things that I should be asking the minister about when she comes in after this?
Well, again, well said. We just absolutely have to stop the exploitation of women in long-term care. We have to provide them, and like we heard, the conditions of work definitely do reflect the conditions of care. And until we respect the workers in there for the work that we do, pay them full-time wages, give them benefits and sick time, give them one job, that'll see, as I said, tremendous results. And again, it takes the political will to do it, to stand up to power, the for-profit corporations, and say, no, we're going to put the senior care, give it the respect and dignity it deserves. As the doctor said, these senior citizens have given to our country. We need to give it back to them.
Got about a minute left here. Let me give 30 seconds to Dr. Sinha and 30 seconds to Donna Duncan. Go ahead, Dr. Sinha.
Yeah, I would just say, I think we have a very dedicated minister for long-term care, and I really would just say, what's holding her back from getting these things done? What does she think that she needs from all of us to get action now? Because we have our list, and I want to know what's the barrier for her to do these things.
That I will ask. Okay, Donna Duncan, last word to you.
Yeah, just to echo Samir's, how can we help? We need to, if we're going to do this, we all have to do it together. And certainly we've heard a lot of common refrains today. Let's build a process, put a stake in the ground, say by this date, this will happen, clear out all of the impediments, and let's just go. So what does she need from us to make that happen? We're here to help.
I want to thank 4 of the most thoughtful voices on this issue for gathering for us tonight on TVO. Sharleen Stewart, Amit Arya, Donna Duncan, Samir Sinha. It's great of all of you to share so much time with us and our viewers this evening. Take care, everybody.
Thank you.
Thank you.
Thank you.
The Agenda with Steve Paikin is brought to you by the Chartered Professional Accountants of Ontario. CPA Ontario is a regulator, an educator, a thought leader, and an advocate. We protect the public. We advance our profession. We guide our CPAs. We are CPA Ontario. and by viewers like you. Thank you.